Good morning or afternoon, everyone. My name is Thomas Pryor, and I'm with the CMMI, or Innovation Center Prevention and Population Health Models Group, where I'm involved in a lot of the Healthcare Innovation Awards from round 1 and 2, and more specifically a collaboration site related to community health workers. I would like to welcome you to today's interactive webinar, the title being Leveraging Managed Care to Support Community Health Workers and Promote Population Health. Integrating community health workers into the healthcare force is a growing strategy for increasing access and improving population health outcomes while decreasing costs. However, many states and plans are faced with challenges to find sustainable financing mechanisms to support the community health workers in these systems. Managed care organizations, or MCOs, are one entity that has successfully developed and implemented models to incorporate community health workers into their teams. The Association of State and Territorial Health Officials and Trust for America's Health, with support from the Health Resources and Services Administration and the de Beaumont Foundation, have collaborated on this webinar to highlight some various models that Medicaid managed care organizations, or MCOs, along with public health, are using to finance and support community health workers. Next slide. The objectives for today's webinar are to describe the importance of building the effective partnership with Medicaid and public health to achieve population health goals. Here, why states can use MCOs as a Medicaid coverage of community health workers and how it is beneficial. Discuss how states can use the MCO contract as a policy and financing lever to support population health goals, and to examine some models of MCOs that have successfully financed community health workers. We have an esteemed panel of experts that will be speaking with you today about what they believe Medicaid coverage of about the belief of Medicaid coverage of community health workers and their benefits. They'll discuss the importance of building an effective partnership with Medicaid and public health to achieve population health goals, ways states can use the MCO contract as a policy and financing lever to support population health goals, and one model of how an MCO has successfully financed community health workers. Following my introductions, all of the speakers will present their slides. If you have a question, you are welcome to post it in the chat box on the screen at any time during the webinar. These questions will be used during the Q&A at the end of today's presentations. You will also have an opportunity to chat and any additional questions during the Q&A session as well. So at the end of today's webinar, you will be directed to an evaluation survey. Please take a few minutes to inform us about challenges and barriers that you are experiencing in your state in providing community support of community health workers, and some feedback of today's webinar. Our first speaker today is Sue Moran. Sue Moran is the Deputy Director of Population Health and Community Health Services for the Michigan Department of Health and Human Services. Moran has over 30 years of experience in healthcare administration in both the private and the public sector. Previously, she served as Director of the Bureau of Medicaid Program Operations and Quality Assurance for the Michigan Department of Community Health. And in that role, she oversaw the administration of the state's Medicaid Managed Care Program, which provides health care coverage to a majority of the state's 2 million Medicaid beneficiaries. I want to now turn over the presentation to Commissioner Moran.
Thank you, Thomas, and good morning, everyone. I'm very pleased today to have the opportunity to talk to you about our topic today, leveraging managed care to support community health workers and promote population health. As Thomas mentioned, I'm Senior Deputy Director for Population Health and Community Services, so I will be speaking to you today from the role and from the perspective of the public health agency within the state. I'm going to touch on 3 topics during today's presentation. I'd like to briefly discuss population health. I'll also touch upon Michigan's experience in utilizing community health workers in community-based settings to address chronic conditions and social determinants of health. And finally, I'll touch upon the Michigan approach to integrate community health workers in the healthcare delivery system through the integration of requirements into the Medicaid Managed Care Program contract specifications. Next slide, please. I'd like to begin with population health. It's a phrase that's increasingly used by many in healthcare, including healthcare systems, healthcare delivery systems, public health, and other sectors. Population health is defined by Kindig and Stoddard as the health outcomes of a group of individuals, including the distribution of health outcomes within the group. So underlying a population health approach is data and the measurement of health outcomes. And that measurement can be defined by geography or other factors as well. So that's an essential component of a population health approach. Health outcomes are determined by a variety of factors that contribute to a person's state of health, such as medical care, individual behavior, genetics, socioeconomic status, one's environment, including their social environment and physical environment. Health status is most influenced outside the clinical setting. We know today that there's increasing evidence indicating that community-based interventions can be effective in changing behaviors, preventing disease, and reducing healthcare costs. We know today that half of all deaths in the United States are due to preventable factors, and chronic disease is a major contributor for morbidity and mortality in our country. Population health recognizes that outcomes go beyond the responsibility of state and local public health agencies and beyond the health delivery systems, and that no single entity can be held responsible for health outcomes. Rather, it's the sum of cumulative factors and collaboration across sectors that makes for an effective population health approach. And in today's presentation, I'll talk about the collaboration between the Public Health Agency and the Medicaid agency as we've worked together to address population health goals here in Michigan. Next slide. Community-based interventions include programs that focus on prevention strategies that address behavioral, environmental, and social determinants of health using non-traditional providers. Community health workers are recognized, if you will, as a non-traditional provider, although I think we'll see that change in time. The American Public Health Association defines a community health worker as a frontline public health worker. We know that community health workers have a close understanding of the community served. They are culturally competent and have an ability to engage and establish trust with the persons that they serve. And community health workers serve as an important link between health and social services and the community. And again, in the presentation today, we'll hear about how community health workers are being integrated into the healthcare system as an important member of the team in addressing chronic disease and social determinants of health. Next slide, please. I wanted to mention a program we've implemented here in Michigan. This is a healthcare innovation. This was made possible through a Healthcare Innovation Award through the Centers for Medicare and Medicaid Innovation. It's called the Michigan Pathways to Better Health, and it's an example of a community-based program using community health workers. In this program, community health workers assess needs related to the social determinants of health and use checklists that trigger pathways or protocols for resolving needs. The community health worker and the client work together to achieve the client's health goals, and the payment model ties reimbursement to intermediate and final outcomes. As we've implemented this demonstration here in Michigan, this program, we've included our Medicaid partners in that we've made them aware of the project. It was implemented in 3 counties and has now expanded in the intervening months to 18 counties, and the program has served over 7,000 individuals. So while Medicaid health plans were not specifically required to participate in the Michigan Pathways to Better Health, we did make them aware of the program that was in their service area and made them aware also that through this program that their clients could be served. Medicare and Medicaid clients were served through this program. And again, the importance of addressing the social determinants of health through the community-based initiatives, and with the new program requirements that I'll speak about in a moment, we have a renewed interest in the community health worker program here through Michigan Pathways to Better Health and community-based programs. Next slide, please. Thank you. So I'd like to shift the discussion for a moment to Medicaid and highlight how the managed care program has employed a population health management framework in its contracting strategy with managed care plans. Federal rules require contracting with managed care entities occur through a competitive process, so on a periodic basis the state will issue an RFP, a request for proposal, and reprocure those contracts. And Michigan is in the midst of a reprocurement process. It has issued the request for proposals, which have been submitted and then are in the process of being evaluated, and once the contractors are in place, the new contract will begin January 1st, 2016. The reprocurement process and the proposal associated with the reprocurement is an opportunity to think about, a vision and how the Medicaid program and the state also wants to advance population health goals. In Michigan's request for proposal, it specifically requires, let me back up, excuse me. In its request for proposal, Michigan Medicaid had a vision to create a Medicaid managed care system that maximizes the health status of the population through evidence and value-based care delivery models. And this vision is built on 4 pillars, and you'll see the first pillar is population health management. It also includes pay-for-value, integrated care, and structural transformation. So the proposal specifically requires contractors to use principles of population health management to prevent chronic disease and coordinate care along the continuum. Contractors must fully participate with payment reform initiatives and initiatives to integrate systems of care and also support structural transformation through active participation in the state's health information exchange and other system-wide infrastructure development efforts here. Public health was at the table. We had a seat at the table during the process of developing the proposal and the translation of the, the vision into all of the various contract requirements. So and it wasn't just public health. This was an agency-wide effort to bring the perspective of all the various administrations within the Department of Health and Human Services to this vision and to this view for the Medicaid program, which serves so many of our state's vulnerable population, as is true for your states as well. Next slide. Because I've introduced a new term, population management here, I again wanted to briefly outline some principles of population management and then show you how those have translated into specific program requirements here in Michigan. There is a citation at the bottom of the slide. This is a blog from the Institute for Healthcare Improvement, and I have found this blog to be very helpful, and there are many other sites as well that talk about and differentiate between these terms: population health improvement, population management, public health, because it can get confusing. When we talk about population management, we're talking about the application of proactive strategies in the management and payment for healthcare services for a discrete or defined population. Population management includes new partnerships among providers and payers, and in particular includes an integrated data support to share information, client-level information, again, in focusing on that continuum of care. And here we see also there's a focus on non-traditional, providers that are typically non-traditional in the healthcare workforce, building new care management models, and shifting from fee-for-service delivery to bearing financial risk for populations served. Next slide. So what does this look like for Medicaid health plans here in Michigan? The population management approach consists of the following. Population management requires specific data analysis. The contractor must utilize data from multiple sources, such as claims, health assessments, community data, specifically to address health disparities, improve community collaboration, and enhance care coordination. The contractor must have a plan to incorporate social determinants of health into their process for analyzing data to support population health. So it's not just claims anymore. It's not just the claims for provider and institutional services and pharmacy. It's integrating other data sources as well and looking at that data to analyze health disparities and, more importantly, address health disparities. There are requirements for the contractor to substantively engage with the community. The contractor must collaborate with a community-led initiative to improve population health in each region that the contractor serves. And also, the contractor must enter into agreements with community-based organizations to coordinate the population health improvement strategies. So while the contract requirements are laid out in the request for proposal, the contract is not prescriptive on how the community health worker requirement is met. Again, there's a requirement to maintain a community health worker to enrollee ratio of at least one full-time community health worker per 20,000 enrollees. So the contract is not prescriptive on how this requirement is met. It's up to the health plan to determine how they can best meet the community health worker requirement. So we've seen an interest on the part of some health plans to contract with entities that already exist in the community. And I mentioned earlier that we do have hubs that were developed as part of our Michigan Pathways to Better Health. Some health plans will choose alternate strategies, and you'll hear from Molina and the strategies that they've chosen to integrate community health workers into their health care delivery system and how they'll be meeting the requirements here in Michigan. I will say that the inclusion of the community health worker requirement into the health plan, through this inclusion of the community health worker requirement into the health plan, it is expected that the return on investment will support the staffing required to meet this requirement. So while there's not a specific inclusion of funds specifically allocated within the rate process saying this is for community health workers, rather it's expected that because evidence demonstrates increasing ROI, and we have more and more of that evidence every day, that through this requirement that the community health workers will ultimately be able to pay for themselves through the prevention and chronic disease focus that they will have. I'll also note here that Medicaid did not need to be convinced of the value of the community health workers' value. Rather, this value was embraced and translated into the RFP and contract requirements. Next slide. So in summary, the Medicaid contract can be a leverage point to introduce and incorporate population health management strategies in support of population health goals, including requirements to support community-based programs and more specifically programs that use community health workers. I've mentioned a few other leverage points for consideration as you think about the integration of community health workers into your strategies, into your population health improvement efforts in your states. Other leverage points include the state innovation model, which we know is based upon the triple aim, which calls for improving population health. And the development of a population health improvement plan is one of the requirements of all of the SIM testing states. Through SIM, states are testing new models of care delivery and payment reform in support of population health improvement. We know that primary care is the foundation of the health delivery system, and patient-centered medical home seeks to improve the delivery of health care services using team-based approach and expanding the focus onto non-medical determinants of health, and we see in patient-centered medical home initiatives the inclusion of community health workers as part of that health team, whether they're based within the practice or the managed care organization or whether they're based in the community. There are many opportunities in the Affordable Care Act, and we know the Affordable Care Act includes a new requirement for community benefit standards, including a community health assessment. That can serve as a powerful tool for mobilizing and building partnerships in the community around population health improvement. And finally, I will note that many state and local health departments are seeking external accreditation through the Public Health Accreditation Board. FAB, as it's known, calls upon health departments, or in our case, the state health agency seeking accreditation, to conduct a collaborative process resulting in a community health assessment that then results in a community health, or in our case, a state health improvement plan. So this can be a leverage point to begin with and build that partnership around synergy for population health improvement and integrating community health workers into strategies. So with that, next slide. This is my contact information. We'll be taking questions here at the end of the session. Again, I thank you for the opportunity to speak with you today, and I hope I've been able to illustrate for you how partnerships can be effective and leveraged to build community health workers into the strategy for improving population health. Thank you.
Thank you, Sue, for that excellent overview of why Michigan has decided community health worker services should be covered in the Medicaid and description of the importance of building an effective partnership with Medicaid to achieve population health goals and ways states can use the MCO contract as a policy and financing lever to support the population health goals. I do want to reemphasize, as Sue just did, that questions will be taken through our chat box. So feel free if you have questions, and if they are specific for Sue and or for Dodie, who we'll be speaking to next. Feel free to annotate that in the question, and then we'll be collecting those through the presentations and then utilize those to kind of navigate our Q&A session at the end of the call today. So our next speaker is Dodie Grovet. Dodie is a licensed independent social worker with Molina Healthcare Inc., where for the past 3 years she has managed the implementation of the community health worker known as the Community Connector Program in the 11 states that Molina Healthcare serves. Previously, she managed the Community Health Worker Program at the Molina, New Mexico office for 4 years. Dodie has over 30 years of work experience in the private and public sectors of social work practice and managed care organization experience. I now want to turn over the presentation to Dodie.
Good morning. Thank you, Thomas, and thank you so much for this opportunity. It is actually an honor to speak on behalf of our company, Molina Healthcare. So during the next few minutes, I'm going to be introducing you to how Molina has successfully financed community health workers. And as Thomas mentioned, that it is, or Sue mentioned, that it is called the Community Connector Program. But for our purposes, I will be referencing them as CHW. We will be looking at Molina's business model approach to hiring community health workers. We'll be reviewing the return on investment documentation and just addressing some strategies on how to sustain CHWs in the healthcare industry. Okay. Here we have Molina Healthcare's vision and mission. Basically, Molina envisions a future where everyone receives quality health care. Our goal, our mission is to provide quality health care to people who are receiving government assistance. And last, we strive to be an exemplary organization. Okay. So we have here a discussion at a glance. We're going to briefly watch a video that just kind of addresses the Molina story, just several minutes on hearing from our actual Molina leaders. Then we're going to specifically discuss lines of business, talk about the CHW employment history at Molina, and then address some financing strategies. Now I will just quickly tell you that the 3 leaders that you will be seeing on this video are actually the children of our founder, Dr. Molina. They have continued in a leadership role of the company. Okay, Megan.
When you go to the doctor, you want to be treated by someone who knows all about healing, a doctor who cares about you, with years of experience helping patients feel their best. At Molina Healthcare, this kind of caring, knowledgeable service is exactly what we give our members. Always have. After all, our company was started by a doctor over 30 years ago.
My father started Molina Healthcare back in 1980. He was an emergency room physician who cared for many patients in the emergency room who were on Medicaid and did not have a family doctor. My father would ask them why not. They would say, because we're on Medicaid, nobody wants to take care of us. So he opened clinics to take care of Medicaid patients. And that was the genesis of this company. What makes us different is the fact that we focused on taking care of a particular socioeconomic group since day one. My father believed that everyone deserved high-quality medical care regardless of their ability to pay.
The way we communicate with our patients has to be in a way that works for them. Many of our patients, our plan members, don't speak English or it's their second language. So we work hard to make sure that we're communicating with them in a way that's comfortable for them and that's congruent with the culture that they live every day.
We understand the challenges that this patient population has. We understand the challenges that the providers who take care of them have. And so we've built our whole company around bringing down those barriers, whether it's barriers for the patients or barriers for the providers.
What started as one clinic in 1980 is now one of the top 500 companies in the U.S., one that touches more people than ever. With more members joining the Molina family all the time, along with an ever-growing network of trusted providers in health plans that meet a vast range of needs, from medical to social to psychological.
They do feel like real people, like they're friendly. They ask you how your mom, how's your sister.
Tengo 20 años con ellos. Tengo 7 hijos y cada uno es miembro de Molina desde chiquitos todos. Me gusta el servicio de ellos, los doctores especialmente. Coming to Molina was always like being with my family. That's what I would say Molina is, more like a family. I feel comfortable with it.
I would refer Molina to any and everybody that's in need. That needs help. That needs health care.
Today, Molina provides the same caring treatment we offered in that first clinic in neighborhoods across the country, with primary care, urgent care, and long-term care for individuals and families, from those with special needs to moms and babies to seniors. Everything we do is to fulfill Dr. Molina's mission to get access to high-quality medical care to every person. And with the recent changes in health insurance, we're proud that his vision is quickly becoming a reality. We continue to treat the same kind of patients we've been serving for over 3 decades, and in every community where we operate, we're pleased to take an active role.
There's something unique about the healthcare industry. The people that we care for literally trust us with their lives, and that's something that we can't forget, not even for one moment.
We do this for people who need it most.
We do it because it's the right thing to do.
Thank you, Megan. So this was just a short introduction of who Molina is. And this next section we're going to be talking about lines of business. Okay. What is our business? You've heard from our leaders that we do it because it's the right thing to do, because it's for the people who need it most. So here briefly we talk about that Molina Healthcare is a multi-state healthcare organization with flexible care delivery systems, including clinics, one hospital, and managed care companies throughout the United States. And the unique thing about Molina Healthcare is that they service individuals who are on government-sponsored healthcare programs for low-income families and individuals. Okay. And this is just a map of where Molina's footprints are right now. You can see that it's all the way from California up to Washington, on the upper right-hand corner, Michigan, Florida, and states in between. And in May of this year, well, I guess it was early spring sometime, we opened up a health plan in Puerto Rico. And I'm actually very pleased to say that we even have community health workers in Puerto Rico. So all over the country, we do have community health workers in every single one of the states that you see on the map. Okay. So the specialized government programs that we were talking about here, first of all, Molina services individuals that are on Medicaid and also the Children's Health, the CHIP program, what they call the CHIP program, Children's Health Insurance Program. And there are approximately 57 million individuals that are eligible for Medicaid all over the country. And these statistics are actually taken from the CDC. Molina also, in some of the plans, not in all of them, but Molina also has special contracts that are servicing the special needs population and also the duals population. Those are individuals that have both Medicare and Medicaid. And then the last program that Molina is also involved in is in the health insurance marketplace. Okay. So let's talk a little bit about the CHW employment history within Molina. Okay. The question we have here is, how do community health workers fulfill Dr. Molina's purpose to treat every patient as if they were your own family? You've heard about Dr. Molina's incredible story. You know, it was his vision for it was his vision to provide services for the underserved. And you know, we all have stories to tell, and certainly our members, our Molina members, everyone here, we all have stories about our lives, about our challenges, and within the Molina context, our members have stories about the barriers that they face every day in accessing care. And I want to say here that I really appreciate Sue comment about social determinants of health. I think that's very, very prevalent, and I'll be touching a little bit on it later. So what's unique about the community connector role, the CHW within a managed care environment? Who are CHWs in a managed care organization, and how do they play on behalf of our Molina members? Well, first of all, our community connector, CHW, they're identified as an extender of the case manager, or in some states we call them care coordinators. And they play a very highly visible role in connecting members with care through a high-touch, face-to-face service. We call them our foot soldiers at the company. They are considered the eyes and ears for the case manager. They're able to report back to the case manager what they're actually seeing in the member's home. What barriers are the members facing, and what's actually driving them to receive their care in the emergency room, or to have to be hospitalized in the first place, or to be re-hospitalized. And we ask the question, why is our member not going to their primary doctor? And what is the member's story? So we find here that this program is not a program that works in silos. The services that the Community Connector, the CHW, provides, it's not a type of job where they work in a controlled environment like our other healthcare professionals. They're out in the community, and every single day they're dealing with barking dogs, they're dealing with angry neighbors, listening to domestic disputes, seeing the unkept homes, and talking to members that are depressed. You'd be amazed how many of our community connectors are actually reporting back issues with barking dogs. You know, it's such an everyday thing, but when you're actually visiting homes, barking dogs and biting dogs actually are pretty relevant. And so even though they meet up with all of these factors, on the positive side, they're having the opportunity to get to know their members. And in time, because of the service that they're providing, they feel welcomed in our members' home. You know, it's one thing to walk up to somebody's door and say, hey, my name is Dodie, and I'm here from your health plan. I'm here to talk to you about the fact that you've been going to the ER quite a bit lately. You know, probably they won't be invited too many times into our members' home. So instead, what we've taught them is to have an approach where they take with the member one of service and of care. So the questions that we want to ask them is, what's keeping you up late at night? What are your primary health concerns? What can we do to help you manage your diabetes? Have you been able to get your medications for your asthma? Did you know that you have a transportation benefit? These are the type of questions that are going to foster trust with our members, which is so critical if we're going to see improved health outcomes for our members. You know, the member is in awe that someone from his health plan would come to his door to be educated about health care benefits, to be offered assistance with finding a primary care doctor, to be provided with information on much-needed community resources, and especially to be given help with removing barriers to accessing care. And in the process of this trust that the community health worker is developing with the member, in the process they are able to find out why the member is going to the emergency room, why he's not going to his assigned primary care doctor, and many of them don't even know that they have a transportation benefit that can take them to the doctor. Or they find out that the member is so severely depressed that he doesn't even have the motivation to take care of his medical issues. And here, most importantly, what I really want to stress here is, most importantly, that the community health worker, that they learn that the member that we thought was non-compliant, in reality, is experiencing some barriers to accessing care. So perhaps the member who has limited health literacy, he doesn't really understand how to take his medicines, how to keep his appointments, or even how to read a bus schedule. He doesn't know how to read or write, and he doesn't even know how to measure his blood sugars or how to manage their child's asthma. So these stories, when our leader says, treat every patient as if they were your own family, these are the real stories that our community health workers are encountering with our members. These are the very real challenges that our members are facing every day. And these are stories that impact health. Okay.
Dodie, this is Thomas. Just to let you know, your voice is kind of coming in and out, so if you can potentially speak a little bit closer to the mic, I think that will help some of our callers.
Okay. All right, will do. Will do. So with the employment history with Molina, it all began in the state of New Mexico in the early 2000s. Molina contracted with a vendor who employed community health workers. Can you hear me okay, Thomas?
Yeah, that's much better. Thank you.
Okay. And Molina contracted with a vendor who employed community health workers to work with our members who were seeking care in emergency departments. And the goal was to assist our members in connecting them to a primary care provider to help them understand how to even navigate through the healthcare system, and then also to make sure that we were appropriately managing their chronic diseases such as diabetes and asthma. So the program actually started in New Mexico, and several years later, in collaboration with our top vendor, which was University of New Mexico, we published an article in 2011 in the Journal of Community Health, which described the partnership between Molina and University of New Mexico. And in part, we described how a 3-year retrospective study was conducted. And we were able to pull our claims report, how much money we were actually spending on our member. And medical costs were analyzed 6 months prior to their intervention, how much we were actually spending during the CHW intervention, and then we looked at the members 6 months post their intervention. We factored in how much cost we were spending on Molina staff, and the payments to our community health workers was also factored in. And in the final analysis, the study documented a 4-to-1 return on investment ratio. For every dollar we were spending, we were saving 4. And in New Mexico, this translated into the millions. We were able to demonstrate strong evidence of improved health outcomes, and also decreased health costs were demonstrated. So when this happened, the leadership at our corporate office, they heard the New Mexico story, the story of changed lives, and the story of cost savings. And this is where the enterprise expansion occurred. As a result of the success of this program that we were seeing in New Mexico, Molina made the business decision to employ community health workers at every health plan. Now, what's unique about New Mexico in comparison to the rest of the enterprise is that New Mexico does continue the vendor relationship with University of New Mexico, but in the rest of the states, in the United States, they are employees of Molina Healthcare. So, and we'll be talking a little bit more in detail on the actual financial structure of that. And then also in Puerto Rico, we are using a vendor. Okay? So how do we find these members who eventually tell us their story? And here on this particular slide, you see how they're identified through various reports. Now, Sue did mention that there are health assessments that are conducted, and this is the same. Molina has the same health risk assessment throughout the enterprise that they use with our members. And these are health risk assessments that are conducted either telephonically or face-to-face. Some of our care coordinators actually go out to our members' homes and also conduct a health risk assessment. And we also have the emergency department utilization report. We have hospitalization reports where we're actually able to see which members are actually going to a hospitalization. We have what we call a high dollar cost report. And we'll be talking a little bit more later on how our community health worker is actually a member of our integrated care team. And so through the recommendation, sometimes through the integrated care team, the community connector is also receiving referrals from the integrated care team, which includes the case manager. Now this last one is the HEDIS missed service report. And again, I'll be touching a little bit more on the business model with the HEDIS, but the HEDIS here primarily is referencing the missed reports, such as if you have diabetes, it shows whether this particular individual is getting their A1C done, their eye exams. It also shows whether a member is getting their preventive screenings for like their breast cancer. So these are reports that we actually use where we can go into a member's home and say, hey, we've noticed that you haven't had your breast exam done in several years. We see that you have diabetes and you haven't had any of your A1Cs done. You haven't been seen by an eye doctor in several years. So this is another opportunity where our CHW can actually develop that trust with our members. Okay. So specifically here on this particular slide, we see what some of the CHW functions are. We have outreach, coaching, that they are the eyes and ears. They help with system navigation and also connector to care. And that's part of why we call them community connectors, is because they are connecting them to care. And as I mentioned earlier, one of the most valuable qualities of the community health worker is the fact that they are hands-on, that they are face-to-face with, whether it's in our members' home, whether they're accompanying a member to a provider's office, or they're advocating on behalf of our member in a community setting. And they do it because of the care, the compassion that they are demonstrating to our members. They have a keen ability to foster trust with those that they serve. So as far as the connector to care here, what we're talking about is that they are helping bridge communication between the member and his healthcare providers. They're connecting members to a medical home, a primary care doctor, and providing information on available community resources. With health coaching and education, they're teaching individuals some self-care behaviors for chronic conditions, providing information about how to stay healthy, and really emphasizing the importance of prevention and primary care. A good example, as I mentioned earlier about the HEDIS alert, is the what we call QNEX alert. QNEX is our claims data, and that's where we're able to actually identify our members that have the missed services. And this includes even with our children, the well child checks. Members are educated on the importance of these preventive screenings and why they're helpful. And under system navigation, here is where we teach the members on how to navigate through a very, very complex health care. They have firsthand knowledge of community resources, and so they'll educate on what are some alternatives to the emergency department. What do we do instead of going to an ER? They also facilitate appointment keeping with providers. And under the area of outreach, you know that a number of Medicaid members throughout the country, a lot of them don't have cell phones. We lose track of them through our addresses. And so this is where we talk about our CHWs, our foot soldiers. They learn the resources out in the community where we can find these members. And that's one of the things too, that with our financial claims data, we can even find out who was the last doctor that our members saw. And so we tap all of these resources on trying to find our unable to contact members. And we'll be talking specifically about one member later on. And so they also remove barriers which may contribute to members. Okay. And here on this slide, we talk about what are some ER alternatives. We teach them about the nurse advice line, where their urgent care centers are in their local areas. We help them be established with a primary care provider. It's not enough to tell somebody don't go to the ER. We really need to be able to give them tools on what some alternatives are. We teach them about calling doctors to find out if there's same-day sick appointments. And here with claims knowledge, basically what that means is that with claims knowledge, it increases our credibility with our members. So we're able to go in there and say, so Joe, you're going to the ER quite a bit for migraines. Let me help you find a primary care doctor that can help you with that. Facilitating outpatient care and then also identifying barriers. Okay. This one, I just wanted to just briefly go over Arthur, who is a real member story. He's a 32-year-old that was referred to a community health worker because of frequent ER visits, hospitalization, and he was reported by our hospital staff that they didn't know how to help the patient. Okay. And what we learned about Arthur, Once a community health worker was assigned to this member, we found out that he was homeless, illiterate, he had no family, he had no telephone, he certainly didn't know how to take his medicine, and we found that he was sleeping in shelters. Okay? So this is what we saw firsthand. We saw that his living conditions, we found out that he couldn't read his medication labels because he didn't know how to read or write. So he certainly didn't understand the hospital discharge instructions. And in the end, we realized that both Arthur and his local providers, they didn't recognize the magnitude of his barriers to receiving appropriate care. Okay. This slide basically just shows what we were able, how we were a managed care organization, how we were able to intervene on behalf of a real member who was told to us by a hospital case manager they didn't know how to help. We assisted him in finding an apartment. We assigned him a home care nurse who was able to arrange for Arthur's medicine for a pill box on a weekly basis. And we actually looked at the cost factor here. We saw, wow, we were literally spending a ton of money on ER visits, hospitalizations, and we realized with the cost factor that it would be more cost efficient to assign him a nurse to help him with a pill box. We arranged for a cell phone. Molina had a program at the time where we were actually giving out cell phones to members who did not have phones. So we assigned them a cell phone, and through the arrangement, through the collaboration with the cell phone, we were able to arrange a phone call reminding Arthur to take his medication. Okay. And this is just a quick slide on the cost impact of this particular member. And you can see that initially, before we had a community connector, we were spending close to $25,000 on a yearly basis. And actually this was a 6-month period that you're looking at. And once we got a community connector, you see that it dropped down to about $13,000, half amount. And then 2 years later, we still have a community connector involved, and the cost is still quite dramatically less than before we had a community health worker involved. Okay. So here, understanding basic human needs, and this is all about the social determinants of health. And again, I appreciate Sue talking about the social determinants of health. Here we find out that the most fundamental basic human needs are food, shelter, and clothing. If these needs are not being met, it's going to be too hard for individuals to really focus on their health care needs. So we help people apply for the community resources that they need. We give them information about their transportation benefits and connect members to various community resources. Okay. So financing strategies, here's the big one. Okay, the next one. Here you see the return on investment. Because we are a managed care organization, Molina has the ability to capture claims raw data, how much money we're actually spending on our members. We talked earlier about the article that we published in part of retrospective study. So what we did, we looked at the utilization and payments, and we looked specifically at how much we were spending in the ER, the inpatient services, the prescriptions, primary care, and specialty care were collected for each individual for a 6-month period before, during, and after the CHW intervention. And for comparison, we also collected data on another sample group who were high consumers of health resources but that were not receiving the CHW intervention. And for all measures, there was a significant reduction, actually in both the number of claims and payments after the CHW intervention. And as I mentioned earlier, after factoring in the cost for Molina to manage the high-risk population, the return on investment was actually a 4-to-1 ratio. And in the state of New Mexico alone, it did result in an over $2 million cost savings. Okay. So here we talk about the Molina's business health model. And, just to capture it in a nutshell, it's a per member per month capitation rate that provides coordination of care for a member. So the question is, do we have the cost factor under our administration or our direct service? And basically the answer to that is that it depends on each state. Each state has different requirements in their state contracts. So whether the cost factor is going to be an administrative or a direct service / medical reimbursement. In 2014, Molina has a what I mentioned earlier, a interdisciplinary care team. That is a model that is in all our states. And so in 2014, it was included as part of the fully integrated care model. So, so like I said, in some states it is considered an administrative cost, and in some states in the contract we're able to indicate that it is a direct service. The community health worker is providing a direct service to our members. Okay. So here, under just this, I think I wanted to go over with you just for some strategies on how to sustain the CHW workforce, depending on what entity you're coming from. I wanted to just kind of briefly go over the grassroots operation. It all started in New Mexico between a managed care company and a vendor. That was the grassroots operation that started with Molina Healthcare. So if your organization is in any kind of relationship with the industry, the insurance industry, build a business case. Show them from the evidence of the published article, from the grassroots efforts of a CHW vendor who started employing just a few CHWs, how that impacted the members' health care. Now, the difference, sometimes I've talked about when you approach a doctor's office, a clinic, or a hospital, or an insurance company. You can go into a doctor's office, a clinic, and say, we can help you have better health outcomes for your patients. We can help you teach your patients on the importance of A1C and the importance of going to an eye doctor. And the doctor can say, that's not a bad idea. Yeah, I think I would like that. But in the end, the doctor's really interested in still having their patients. So even though, we say we want better health for our patients, in the end, the doctor's office really does want better. They want to maintain that patient load. You can also approach a hospital and you can tell them, hey, there's a high incidence of ER visits, at your hospital all over the country. People are just going to the ER just a little bit too much, and we can help you. We have community health workers that will actually teach your patients alternatives to going to the ER. And an ER can say, a hospital can say, wow, that's not a bad idea. Yeah, we really do have a lot of patients in our ER. But in the end, the hospitals are going to say, but you know what? We still want our patients in the ER. Both of those are incomes for their patients. But now you approach an insurance company and you say, hey, we know ways of decreasing healthcare costs. We know ways of improving health outcomes through the use of a community health worker. And an insurance agency, an insurance industry is going to say, really, we're interested in cost savings. Tell me about your plan. And just like everyone has somebody to answer to, and that includes insurance companies. You're aware of the MCQA standards, the federal CDC standards, or the other federal agencies that are overseeing health managed care organizations. And just in the area of the HEDIS alerts, you talk to an insurance industry and you say, an insurance company, and say, hey, we have ways of helping your members keep all those preventive screenings. And so I just want to encourage you to partner with managed care companies and learn to speak their language. Learn to understand that they're interested, they're vested in improving health outcomes, and they're definitely interested in decreasing health care costs. And as I mentioned before, we all have a story to tell. Someone once stated that the point of a newspaper career isn't in the reporter, but it's in the stories. And those stories, every single one of them, start with people. And that's the truth, even with insurance industry. Okay. So by encouraging, and here with Molina, we call them members, and we're very member focused because we're helping them change their stories. So by encouraging members to make healthy choices, they have potential for greater behavior change. We want to teach them the right, how they have the right to make choices. We want to teach them to take ownership of their own experiences. We want to empower them on how to act on their own behalf, how to have strength to cope with adversity and challenges, and the capability of sustaining healthy behaviors. And you know what? We know that we're going to know that we got it right when they're doing most of the talking and they're talking about behavior changes. They're keeping their appointments and they're measuring their blood sugars. They're paying attention to their diet. And ultimately, for this purpose, for financing, sustaining CHWs, when the ER visits and the repeat hospitalizations decrease. Okay? So the benefits. Here, again, talking the insurance language. The CHW, they live in the service community. We see an improvement of healthcare utilization at a lower inpatient, outpatient level, and we can show that we have improved quality of life and health outcomes. We're removing the barriers to accessing care through addressing the social determinants of health. You can also talk to insurance companies and say, you know what, we can improve your provider satisfaction, member satisfaction, and those are very key elements for insurance companies, the fact that members and providers are satisfied. And again, the interdisciplinary care team contribution, and ultimately, by being responsible stewards of Medicaid funds. Molina, through this community health worker, we have demonstrated that we are responsible stewards of Medicaid funds. We have a commitment to being a responsible steward. And so this community health worker, it really truly does reflect Molina's commitment to each of our core values. I champion the work of a community health worker, and I'm very passionate about the incredible impact and the continual potential that community health workers have for every single Medicaid recipient in the United States. It truly reflects our commitment to our core values, and I honestly believe that what Molina has is very unique, and I champion the work of the community health worker, and I thank you. Thank you so much for this opportunity to share with you and welcome any questions. Thank you very much.
Well, thank you, Sue and Dodie. We want to move to the question and answer session, but it's clear that you both speak with a lot of passion, conviction, and experience. As I said, we've had a series of questions that have already been put into the queue, and we're going to kind of work through those questions in the time that we have left. I do want to just reiterate for those of you that may have joined late, if you have a question, simply put it into the chat box, and we will work to get those questions answered in the time that we have. Well, I'm going to start with a couple from the beginning of the call, and these came from, forgive me if I mispronounce your names, Lori Salis and Tia Yancey. And I'll direct this one specifically to Sue. And it was questions if it was possible to get a copy of the Michigan plan, and that do you have any suggestions or examples of documentation templates for the community health worker?
Okay. Just a point of clarification, when you ask about the Michigan plan, I'm assuming that you're referring to the request for proposal that lays out all of those Medicaid requirements. So I would ask if you would email me, and then I can forward your request on to folks who can provide you with that. And if it's not the Medicaid request for proposal that you're asking about, let me know what it is, and I can certainly assist with getting you the information. In terms of the documentation template for the community health workers, again, we have needs assessment checklist and documentation that we used in the Michigan Pathways to Better Health. In the Medicaid program, each of the health plans are going to be developing their own processes and supportive documentation. So, that would be a plan specific. The state is not prescribing a template that the Medicaid health plans must use for that documentation of the community health worker assessments or plans. I hope I've answered the question.
Thanks, Sue. I also want to turn our attendees to the chat box for a variety of links that our colleagues from both ASTHO and from TIFA have been adding as additional insights or linkages to some of the questions that have been answered too. So for those of you on the call, please do look at the chat line and cut and paste those links that have been provided as well. Let me go to a question that was identified for Dodie, and this comes from a Beth Littleterry. What are the skill sets that community health workers have to be able to instruct a person about taking medications and managing the symptoms and problems that they may incur?
Well, the skill sets, that's a really good question. When I talked about that they are a member of the interdisciplinary care team, Molina has, when it was initially rolled out in New Mexico, they had a more active role in some of the teaching about chronic conditions. Now, what we do now is we, because they're considered our foot soldiers, they will make that referral to the case manager, a nurse, who will then communicate with the actual member and give them the information. So when we talk about their role as a community connector, that's what they're basically doing now, is they're connecting them to the appropriate resource person, whether it's someone in the community, whether it's their physician, or whether it's a nurse back at Molina. So that would be the skill set, is just being able to identify when the member says, well, I'm having trouble taking my medication. They take that information, and then they will say, let me take this back to my nurse, that's the nurse that I'm working with, and I'm going to make sure that she gives you a call. So that would be the skill, is just being able to recognize and identify that the member needs assistance.
Thanks, Dodie. Questions going back to, these are directed to Sue regarding the Michigan activities. This one's from Joan Clary. In Michigan, is Medicaid funding for community health workers coming out of the health plan administrative budget or out of health service buckets? Did Michigan Medicaid need to get CMS approval either through the SBA waiver or to be able to pay for the community health worker services? And what community health worker services are covered in Michigan through the MCO contracts? There was a relevant question also from a Shavane Lamb, again, apologize for mispronunciation, asking about funding sources. So these kind of go together. Direct that to you, Sue.
Okay. Those are great questions. As I mentioned at the beginning of the call, I represent the public health perspective. I'm going to do my best to answer the Medicaid questions. And if you still have questions after I've provided an answer, again, you have my email. Feel free to send me a follow-up question, and I can link you with folks in our Medicaid program. So you begin by asking about funding. Let me go back to the requirements here in Michigan for the community health workers are a staffing requirement. The plan must have a ratio of 1 community health worker for every 20,000 enrollees. So they become part of the administration, if you will, requirements of the contract. Now, I did mention also that there's flexibility in terms of how the plan meets that staffing requirement. They can employ their own community health workers, as Molina does through its community health worker program, but Molina also mentioned in some markets they use a vendor. So there's an opportunity there for the plan to determine how best they're going to meet that staffing ratio. You won't see community health worker as a covered service in the contract. What you'll see as required covered services are things like health education and case management. Again, Molina described how they use the community health worker as an adjunct or a partner with their case management program. So that's how they've structured it in terms of how they administer services within their health plan. In terms of approval, yes, the CMS regional office has to approve both the contract, including all of the contract specifications, as well as the rate. The rate paid to the health plans has to be actuarially certified, and that is subject to an approval process by CMS as well. And then you asked what services are covered. Again, the contract specifically will not say these are the specific CHW services, rather it describes expectations of the community health workers and community health workers addressing social determinants of health, linking individuals to services like primary care services. And again, Dodie did a wonderful job of describing how community health workers can address social determinants of health as well as physical needs and many other issues as well.
Thanks, Sue. This question comes from Brenda Richards, specific to Dodie. We'll start with her. Are all the states with the Molina program, those community health workers achieving the same or similar return on investments in all the states? Or how are you packaging this information to garner more reimbursement and support for increasing the number of community health workers in the workforce? Dodie?
Okay, so the question is, are we seeing the same return on investment in the other states? Did I hear that correctly, Tom?
Yes.
Okay, so actually the enterprise, the expansion on the enterprise was started probably in late 2013. And specific to this return on investment, we, in the spring of 2014, we started talking about how to create measurements, clinical measurements, to be able to conduct this evaluation. Because when they were in New Mexico, we didn't really have an integrated care model the way it is now. So we need to be able to pool. We need to be able to pool clinical information specific to what the community health worker is doing. So right now we are actually in the process of doing the analysis. So we haven't gotten the raw data yet because it's still being collected. We have to be able to allow the program to be in place for a little while in order to be able to capture the claims raw data that is needed. Did that answer your question, Brenda? If again, like with Sue, if I can be of further assistance, feel free to email me later.
Thanks, Dodie. A couple questions that were identified by a few of our participants, and I'll send this one back to Sue, had to do with, well, specifically, how do you risk stratify to determine which patients will receive a community health worker? This is from Stephanie Elliott. And Kim Burton also followed up with a question, again for you, Sue, as to the enrollee ratio of 1 to 20,000, which she thought seemed unreasonable, but regardless was, what is the CHW enrollee ratio? She wanted to clarify that information. And then there was a follow-up question also for Dodie as to what the ratio is in the Molina model. So we'll start with Sue, and then maybe you can add your piece, Dodie, after that.
Okay.
Thomas, this is Sue. Would you repeat the first question? I got clarity on the ratio.
So the first question was from a Stephanie Elliott, how do you risk stratify to determine which patients will receive a CHW? And the follow-up from Kim Burton was clarifying the enrollee ratio of 1 to 20,000.
Okay. So in terms of risk stratification, again, the state is not prescriptive about how patients are risk stratified. The state does say in its context that the plan must have a process. It must have a process for risk stratification of clients, and that process must include multiple data sources and must include sources that address the social determinants of health, in addition to data sources like claims and utilization. So I can't specifically answer that because, again, each plan is going to develop their own processes to meet that requirement. But again, I think Dodie did a nice job of describing how Molina specifically uses multiple, not only data sources, but referral sources as well. She talked about how the hospital ER contacted the case manager, and I assume in that environment in Molina that providers also can refer to Molina when they have a client who has, multiple and complex needs. In terms of clarity around the ratio, I think it's a little bit of art and a little bit of science, but it's looking at the sort of best available evidence on return on investment for community health workers and where those staffing ratios might be targeted, taking into account some estimates of complexity within the population. And I guess that's about as much as I can offer in terms of how the ratio was established. I do know that, on an ongoing basis as the program is brought up, and again it starts in January, there are requirements for health plans to seek approval from the state and, as I mentioned earlier, describe their plan for addressing social determinants of health. And I suppose there's some room to maneuver on that ratio if over time it's demonstrated that, maybe it should be higher or lower or address specific subgroups, et cetera. I guess we're going to learn a lot as we go forward.
Thanks, Sue. And Dodie, is there any clarification you can give to how enrollee ratio is from Molina model?
Sure. Well, each state has different requirements as far as the ratio. I know, like, well, Sue talked about Michigan, and I know, like, in Ohio, it has like a 1% of the highest risk members have to have a face-to-face contact, and they are utilizing community health workers for that purpose to go in and meet with their members. So, like, for example, in the state of New Mexico, you know, it's considered a frontier state because it's not very highly populated. But because of the strong commitment, they have probably close to 40 community health workers throughout the state of New Mexico that are living in the service communities. And our bigger states like California, the states that have the bigger Molina membership, California, Washington, Ohio, they seem to have a higher ratio of community health workers. But I think to say that it is based on a state, to see if it has a specific state requirement, that's what they're actually basing it on. And then also corporate leadership is allowing the state leaderships to kind of take a lead and looking at their individual budgets. And then so they look at their individual budgets and individual state requirements. And I just wanted to just kind of piggyback also about the risk stratification question. Again, the insurance industry, at least for New Mexico, and we have them all over the country, the health risk assessment. That's how we stratify community health workers' assignments. If they are, by taking the health risk assessment, we find out what the members' needs are. Based on what those members' needs are, that's how we determine whether a community health worker should be involved or not.
Thanks, Dodie. Going back to Sue, this question from Marcus Johnson. Can you describe the process you, the public health, took to get a seat at the table during the Medicaid MCO procurement process?
Sure, I can describe the process. I guess the short answer is we were invited to have a seat at the table, and I guess I would say as an organization we're what's known as a super agency. That is, in our agency at the time that this proposal was being developed, we were the Department of Community Health, which includes Medicaid, public health, behavioral health, and services to the aging. We've since become the Department of Health and Human Services. But I would say as an agency, we recognize the importance of the contributions of each of our administrations to something as statewide and important as our Medicaid health plan procurement process. So I guess in that regard, we didn't have to demand a seat. We were invited, and our perspective was recognized and I think valued. I think it also helped, as you'll note from my bio, that I previously worked in the Medicaid program as well. So I had experience administering the managed care program and had experience in previous procurement cycles as well. So I had both experience and spoke the language, but also, recognized the importance of the viewpoint of the various administrations in an initiative such as this.
Thanks, Sue. I know we're coming up on the end of our call. We do have a few more questions. I'll just ask the speakers if they have time to stay on for a couple more minutes and answer some more of the questions. Hopefully without putting you on the spot.
I could probably stay for one more question, then I'll need to go. So.
Okay, very good. Let me, Dodie, can you stay for a couple minutes? Or?
Yes, I can.
Okay. One last question then for Sue. This goes back to Lori Neuer. Can you describe how the community hubs are viewed by MCOs and the role they play in population management?
Sure. Again, because of the new Medicaid health plan requirements, I think that there's a lot of interest in the community hubs because they'll be a great solution for some health plans in some market areas. In terms of the role that they play in population health, we know from the work that we've done through the Michigan Pathways for Better Health that our top 10 chronic conditions include hypertension, depression, tobacco abuse, arthritis, diabetes, anxiety, hyperlipidemia, asthma, obesity, and weight loss. And we know that their needs, the top 10 needs identified by clients include housing, dental care, transportation, food, clothing, utilities, health insurance, primary care and linking to those services, education, and employment. So as we noted during our discussion about population health, many of the factors impacting a person's health status are outside of the medical care delivery arena, and community health workers serve an important role in addressing, again, the social determinants of health and linking individuals to services, and in particular, healthcare services that can help manage or, and in some cases, prevent chronic disease and complications.
Thanks, Sue. I know we have limited time, and I will answer one or two more questions. Sue's got to leave. I think it's also important to know that we are going to have plans for those of you that have questions that don't get answered today to get those answered and shared and out. So please take solace in knowing that if your question is not answered today, that we will certainly look to get you associated responses to that. And I know Sue had to leave, but again, reiterate appreciation for her participation and insights today. A question here that I will add to direct to Dodie. This goes from a Kamisha Tate. How do you suggest getting a medical practice that hasn't used community health workers to buy into the need over a long period of time?
Medical practice meaning like a clinic?
Yeah.
Well, I think that if they have like rounds, medical rounds, or just for me, it's all about building relationships. And if you are a vendor that provides the services of a community health worker, building the relationship with the primary care team, and social determinants of health. We've talked a little bit about it here. And it's really big. It's really big right now in the world of public policy. So if within the clinic, if you're able to just really talk about the social determinants of health and really talk about how important that is, and building the relationship with the insurance companies that are, for example, if you have a patient that is being non-compliant, find out what insurance companies that they have, and find out what some of those benefits are, and then sell the program. And Kanisha, if you want, I can also put you in touch with some of the clinics that are not Molina clinics that provide the services within the clinic. I can actually put you in touch with those too. They're called the patient-centered medical homes. There's a really big one here in the state of New Mexico that has community health workers within their clinics. We actually have several vendors here in New Mexico that have them within the state. And if you like, Kanisha, I can put you in touch with some of those individuals to just give you some more ideas on how to actually incorporate them within the clinic.
Sorry, Dodie, we lost you. It was faded out just a little bit toward the end, but just to reiterate, I heard you said that you would be willing to help kind of put participants in touch, connected them.
Yes.
Two more questions for you, Dodie, and we'll close if that's okay.
Sure.
One is kind of adds to what was just mentioned. This is from Sherry Oley. Is it possible for the presenter for you to help state health departments to connect with state-level Molina community health worker efforts? Or is there another mechanism for that?
Repeat the question, Thomas.
Is it possible to help state health departments connect with state-level Molina community health worker efforts?
Is it possible to connect state health departments with Molina's
community health worker efforts, I suppose, in those states, is how I'm reading that.
Yes. If you like, I can, was it Sherry that asked the question? Yeah. Sherry? Yes. Again, I would be happy to put you in touch with the individual state leaderships of the community health workers. That is a workable solution.
Perhaps we'll work with our colleagues here at ASTHO and TIFA with you to kind of, communicate that or put that out so we can share that with the group.
Yes.
Great, thank you. One last question. It was asked from a couple different callers is, how are the CHWs trained, and are they required to have a certain level of education or certification in the Molina plan?
Yeah, that's a really good question. So how are they trained? What we did was when we implemented the program, we looked at a number of different CHW certification requirements throughout the country. And so what we did was we pulled from all the different certification requirements and really tried to individualize it to the Molina needs. So we look at the soft skills. We talk about trust, workplace ethics, communication skills, what it means to conduct a home visit, professional boundaries. We have specific training around social determinants of health, safety. Safety is a really, really big one, teaching people how to be safe. And then also about capacity building. So that's what we've done is we've developed that curriculum. And then there are some states, at least three states that have CHWs that are required to be certified. And so all of those states that have that particular state requirement, we have them fulfill those CHW requirements. And so like recently in the state of Florida, we were able to show the state of Florida under the CHW requirements that Molina actually met the CHW requirements, and so we were able to grandfather some of those all of the CHWs based on our CHW training material that we have. So we look at state requirements, but then we also look at how does that impact the individual member.
Thanks, Dodie. And we have one last question to close out today's call, and this comes from Joanne Cleary. To what extent has Molina encountered occupational, territorial, or turf issues on part of other health disciplines with the introduction of community health workers' role across the United States? And what do you do, or how do you respond when this happens?
You know, Joan, to my knowledge, I don't know that we have run into any kind of pushback. But, I come from a social work background, and I'm all about building relationships, being very systems-oriented. And I can tell you that once individuals understand the value of what the CHW is doing for that particular patient or client in whatever venue it is, they actually are quite appreciative. So I personally have not heard of any kind of pushback or any kind of negative exposure or feelings towards what the CHW is doing. In the state of New Mexico, I believe it's even required. I think in Michigan it sounds like it is too, but even in the state of New Mexico it's required. CHWs are required as part of the managed care contract. So I'm not aware of any, Joan. I'm sorry. And that's actually good news.
Well, thank you for that. And so at this time, I do want to bring it into our Q&A session. I want to thank you again for joining us today. As I mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's webinar. Please take a few minutes to fill this out, as it provides ASTHO and TIFA some useful information for their future projects. There's also questions related to the work you are doing to improve financing for community health workers in your state. I also want to thank HRSA and the De Beaumont Foundation for sponsoring this webinar. And I would always like to thank our speakers, Susan Moran and Dodie Grovet, for their expertise and insights. The presentations from today's webinar will be available on ASTHO's website within the next 1 to 2 weeks. The web address is on the screen now. And if you have any follow-up questions, please contact Anna DiBiasia, Megan Miller, or Courtney Bartlett, whose contact information will also be on the screen. We hope, as I said before, to answer the additional questions and communicate those out to you in the near future as well. So we hope that all of the listeners found this to be a webinar that was useful and as a resource, and we share the link with others once it is available. And also reiterate that there had been other links provided through the chat box to other efforts that had been provided both by ASTHO, TIFA, and others. And I would just again remind you to take advantage of those learnings and add that to your repository. Again, thank you for your time and attention today, and enjoy the rest of your day. And that will conclude today's webinar. Have a great day.
Thank you, Thomas.
Thank you.